Hello and welcome. In this video, we'll be discussing selective diseases of the liver, starting with alcoholic liver disease. Alcoholic liver disease requires a minimal amount of alcohol, and this is usually described as more than 80 grams per day carried on over greater than 10 years. 80 grams per day is about 6 beers or 8 1-ounce shots of liquor. And even with this considerable amount of drinking, only about 10% of these drinkers will get cirrhosis. Women are susceptible to alcohol in ways that men are not, so there's less dose needed for women. The metabolism of alcohol is worth learning. One starts with ethanol, and there are two pathways for metabolism in the normal cell. In the cytoplasm, there's alcohol dehydrogenase, and then in the endoplasmic reticulum, there's the microsomal ethanol oxidative system with the key enzyme 2E1, and that forms acetaldehyde. Acetaldehyde is metabolized in the mitochondria by acetaldehyde dehydrogenase into acetate. Acetate can be formed into fatty acids, and when combined with glycolysis, which starts with glucose and through a series of steps forms glyceraldehyde 3-phosphate, and remember this is in balance with DHAP, these can form triglycerides. If the glyceraldehyde 3-phosphate continues in the glycolysis pathway, it will form pyruvate. Pyruvate can feed into the mitochondria and go into the electron transfer chain of the tricarboxylic acid cycle. The key products of alcohol metabolism are the production of NADH. And when the NADH-NAD ratio gets high enough, it starts driving these other pathways. It drives acetate to form fatty acids. DHAP is driven to form glyceraldehyde 3-phosphate, and so one gets an increase in triglycerides. Pyruvate can go on to form lactate in situations of anaerobic metabolism using lactate dehydrogenase, but it can also be driven down this pathway with NADH. And it is from these pathways that we see the key metabolic pathology of alcohol. The increase in lactate gives a metabolic acidosis. By driving the pyruvate into lactate, it decreases the amount of pyruvate going into the mitochondria, which decreases activity in the electron transfer chain, decreasing the production of oxaloacetate. And this leads to a decrease in gluconeogenesis, and patients get hypoglycemia if they aren't eating. In the liver, increasing the amount of triglycerides lead to steatosis. One last note, chronic ongoing use of alcohol induces the 2E1 cytochrome enzyme, and this is important in acetaminophen metabolism. And heavy drinkers can get Tylenol toxicity at much lower doses than normal people due to this increased rate of metabolism. Pathology of the liver can occur in multiple forms simultaneously. One can get fatty liver at the same time as alcoholic hepatitis and have underlying cirrhosis. So these are not either-or conditions, they are the three overlapping conditions of alcoholic liver disease. Fatty liver disease is due to increased triglycerides, and in the acute situation, this is due to the increased NADH-NAD ratio along with other metabolic products. The accumulation of triglycerides in the liver is also associated with abnormal lipoprotein production. You can get this even with mild alcohol ingestion. It is, however, completely reversible. It is asymptomatic, and the only way one would recognize it in routine practice is after drinking, one can see an increase in the alanine transferase. Alcoholic hepatitis is a subacute illness associated with heavy drinking. And for reasons that are unknown, there is an acute inflammatory infiltrate of neutrophils that harm the hepatocytes. The degeneration of the hepatocytes has a very characteristic pattern in which they form Mallory bodies. And in the hepatocyte, these form a very characteristic clumpy pink breakdown product that allows for the diagnosis of the entity. The patients tend to be ill. They have malaise, fever, jaundice, and on lab testing, liver dysfunction. And the diagnosis has to be made by recognition of the pattern of findings and a liver biopsy to show the presence of the Mallory bodies. It's a highly variable disease course, but without stopping of drinking, it does have a significant association with liver failure and death. Alcoholic cirrhosis has no distinctive features. Cirrhosis is the common end pathway for all chronic liver diseases. The diagnosis, therefore, depends on clinical criteria. There are 5 viral hepatitides, and they're conveniently labeled by the first letters of the alphabet. It's really not necessary to learn all of the letters, however. For example, when we take a look at E, E has the equivalent clinical presentation of hepatitis A, and one can suspect hepatitis E when there is a hepatitis A type pattern, a history of foreign travel, and a negative hepatitis A virus test. The only significant finding is that in pregnant women, it has a high association of fulminant hepatitis, which can be fatal. Hepatitis D has a defective RNA, so that it has to have B to form its hepatitis B surface antigen. It can either be a co-infection or a superinfection, but it really doesn't have to be suspected without underlying B to allow it to be active. So viral hepatitides in working medicine are A, B, and C, and they are worth learning. They are single-stranded RNA viruses, except for B. This is a double-stranded DNA virus, which has a circular form. And the only reason one cares about this is because it's a double-stranded DNA, it can insert into the human genome and form hepatocellular carcinoma. The other double-stranded DNA virus that can do this is human papillomavirus. Hepatitis A virus is transmitted by fecal-oral. It has an incubation of about 1 month. It very rarely has a fulminant form. It is not chronic. Its diagnosis is made by IgM to prove that it's an acute virus, anti-HAV, hepatitis A virus. And its natural history is that it is self-limited. Hepatitis B is transmitted in America as a sexually transmitted infection more than parenteral. It has an incubation of about 3 months. It does have about a 1% fulminant rate, so quite uncommon, and it only has about a 10% chronicity rate, so most of the time it's a benign self-limited disease. Its diagnosis is established by hepatitis B surface antigen, but in the acute, as we'll discuss under testing, you have to have a second test for the window, which will be an IgM hepatitis core. Its natural history is that it tends to do well, but it has a number of possible complications we have to discuss. It can go on to form cirrhosis, hepatocellular carcinoma, and it is associated with immune complex disease, which is the vasculitides like polyarteritis nodosa. Hepatitis C is almost universally transmitted by parenteral means. It has an incubation of about 2 months. Fulminant disease is very rare, But now note the key difference. It's much more likely to go on and to be chronic. Diagnosis is by finding an anti-HCV antibody, but notice it's not an IgM. We do not have a good way of differentiating acute and chronic disease by testing. It's mostly done by history and enzyme levels. The natural history is the same as hepatitis B. It can form cirrhosis. It can develop hepatocellular carcinoma. And it has immune complex diseases of glomerulonephritis and cryoglobulinemia. So this then forms the foundational ideas of the viral hepatitis. The pathology of the viral hepatitis is not caused by the infection, but by the immune response. The infected hepatocyte will expose the abnormal viral antigen on the MHC1 protein, and this is recognized by the cytotoxic lymphocyte. This will force apoptosis through two mechanisms. The first is the Fas receptor, the cytotoxic lymphocyte secreting a Fas ligand, and this will go down a death domain to activate caspase 8. The caspase cascade will activate the executioners, and that will force apoptosis. The other mechanism is using the protein perforin to inject granzyme. Granzyme activates caspase 8 and again goes down the cascade to apoptosis. The pathology is one of hepatitis, and for most forms of hepatitis, this is periportal. So if one forms a portal triad with the hepatic artery, portal vein, and bile ductual, together with the hepatic vein, and then there are the arrays of hepatocytes. Inflammation starts in the periportal region and then extends out into the hepatocytes. And that is a classic hepatitic pattern for almost all of the causes of hepatitis. If one looks inside the hepatocyte, it will have a very characteristic what's called a ground glass appearance due to the viral particles itself. And individual hepatocytes undergo apoptosis, and these have gone by various names as they've been recognized, one of which is a Councilman body. The key pathology of progression, however, is the development of fibrosis. And fibrosis tends to start periportally, and as it extends more and more across the triad, that is how we stage the likelihood of developing cirrhosis. All liver disease has 4 possible presentations. It can have an asymptomatic presentation in which one recognizes abnormal enzymes, and in a hepatic pattern, this is an elevated transaminase. It can present as an acute hepatitis, which is a flu-like illness with jaundice, pale stools, and foamy brown urine. Chronic disease can present as cirrhosis or immune complex disease. Immune complex diseases include glomerulonephritis with nephritic syndrome, cryoglobulinemia, and vasculitides such as polyarteritis nodosa. It can also present as liver failure, either by the cancer, which would be a hepatocellular carcinoma, or by the spectrum of chronic renal failure, in which the clinical hallmark is an encephalopathy. So the physical exam really depends on which of the clinical presentations your patient has. Testing for the viral hepatitis for A, B, and C include IgM, anti-hepatitis A virus for A, hepatitis B universally is hepatitis B surface antigen positive, but in acute disease there is a problem, which is this. If one takes a look at the disease, from the time of infection, the hepatitis B surface antigen rises, and later then one forms the anti-hepatitis B S antibody. We have this region in which the two are equal. Immunologists call this the zone of equivalence. Clinically, this is called the window. And when you test in here, testing is negative because the two cancel each other out. Therefore, this window has to be covered, and the current test we use is an IgM anti-HB core. We don't have a test for acute hepatitis B. We use an anti-hepatitis C virus antibody, and one diagnoses acute by the clinical history being within a few weeks of exposure and the presence of an increase in ALT, which is 8 to 10 times normal. The natural history depends upon the virus. Hepatitis A is benign, self-limited, and does not have a chronic phase. Hepatitis B goes on to chronicity in about 10% of cases. And hepatitis C goes on to chronicity in about 80% of cases. Of these, about 20% will go on to cirrhosis. And of patients with cirrhosis, about 20% will go on to hepatocellular carcinoma. So if one is asked what is the most likely outcome of hepatitis C infection, it would be one of a chronic carrier. The complications include cirrhosis and hepatocellular carcinoma, and then the immune complex diseases. The treatments are different for the viruses. For hepatitis B, the treatments are actually pretty unsatisfactory, and they consist mostly of nucleoside analogs and pegylated interferons. The trouble with these is that they have a high relapse rate and they are immune modulating. And so for hepatitis B, it is important to differentiate carrier status from chronic active hepatitis, which has much higher likelihood of going on to cirrhosis. And this is done by looking at two things: by looking at the activity of the virus and by looking at the intensity of the immune response. Inactive virus is associated with the presence of an anti-HBe antibody or low virus particle counts. Active disease has hepatitis E antigen present and high viral counts. We don't have a test for measuring cytotoxic lymphocytes, but we can certainly measure their effect by looking at the level of the ALT. If it is normal, that is a sign of little immune response. But if it is markedly elevated, then that is an immune response. And so the patients that must be treated despite all of its limitations are patients with chronic active hepatitis. We do have excellent treatments for hepatitis C, and these are due to the development of direct-acting antivirals. It's beyond the scope of our discussion here, but these are proteins that target the proteases, the non-structural proteins, and polymerase inhibitors. That brings us to the end of this video. We continue discussion of liver diseases in the next video, which will include the less common diseases outlined in the algorithm and discussed in the lecture on clinical pathologic correlation.